So hello to everyone. We are here for a new EasyChem chat. I have the pleasure today to welcome my friend Bruno Levy from Nancy, France. Bruno,
Hi.
Pleasure to see you. So we are going to talk about a specific issue with you today, which is temperature management in patients with cardiogenic shock. So my first very basic question is, why do you think that the temperature is important in the management of acute heart disease?
Thanks, Fabio, for this question. First is physiology. And you know that hypothermia, moderate hypothermia between 32 and 34, was associated with a decrease in heart rate, but also a decrease in cardiac output, which is generally proportional to the decrease in heart rate, but also, and especially in animal models, to an improvement in cardiac contractility and to a decrease in myocardial oxygen consumption, which is higher than the decrease in cardiac output. And this might be a very important point for patients with cardiac shock, especially patients with ischemic cardiac shock.
We have some data, for example, in myocardial infarction, when you use, hypothermia before opening the coronary artery. Do you think, although we're not cardiologists, do you think that this is something that is still something to be studied further? Would be something that would be more used in the future in some patients?
It's a difficult question. Results are confusing, and recent paper that use intravascular device demonstrate an increase in the delay between the opening of the artery. So I'm not sure that it's a good point. I think you have to open the artery and the intensity is to treat the patient.
Of course.
I'm not sure that hypothermia is good as a place at this time.
Let's move to the more severe cases, as you said, myocardial infarction. We don't treat these patients in the ICU. Now, if you move to cardiogenic shock, which are the data that we have in cardiogenic shock without mechanical support that say that maybe temperature has a therapeutic role?
Okay. There is a paper that was published by Furno from Olga Thiel teams, and this paper was published in Circulation, and they compare patients with cardiogenic shock without cardiac arrest, and the randomization was in the coronary labs, and they compare 33 degrees to 36. So small studies, and they did not find any differences for cardiac power index or the amount of norepinephrine infused or lactate, for example. But the study was not powered for mortality, and they just studied the hemodynamics effects of hypothermia. And as you know, in patients with cardiogenic shock, ischemic reperfusion is very important. So you have also to consider other properties of hypothermia.
Now, what is quite intriguing to me that you mentioned, of course, myocardial infarction. You said that the data are limited, at least in terms of long-term outcome. You said that cardiogenic shock, we have data, but basically these are physiological data. And now we come out with the randomized trials directly in the most severe patients, those with cardiogenic shock. Can you tell us a little bit why you made the study and which was the expectation behind the study?
Yes. First, we perform, and you also CPR. And in CPR, which is just a clinical impression, using hypothermia in very, very sick patients, very prolonged cardiac arrest, we have the impression that the patient might improve, especially for ischemic reperfusion injuries. Second, we performed animal studies, and we found that hypothermia was associated with less fluid and also with a better cardiac function. So we performed a randomized multi-center study, which was called the VA-ECMO study, and the study was recently published in the journals.
Bruno, it's quite interesting to see that you randomized 300 patients into this randomized trial, comparing hypothermia, 24 hours, 33 degrees, to slight normothermia, 36 to 37 for the same period with a prolonged rewarming phase. And you showed 80% difference in mortality between the two groups. Of course, mortality was lower in the hypothermia group. So in terms of p-value, the p-value is, I think it's 0.07. The study is considered to be neutral. We cannot refute the hypothesis. Now, my point is, how would you clinically implement the results of these studies when managing patients with cardiogenic shock with VA-ECMO?
Thanks, Fabio, for this important question. My opinion is, first, using hypothermia with ECMO is very easy because we use the heat exchanger, which is included in the device, so no cost. Second, and it's very important for me, we did not find any adverse effects. The occurrence of bleeding and the occurrence of an infection was the same, and the ventilatory 3 days was also exactly the same. So if you don't have any contraindication for hypothermia, such as massive bleeding, which might not be correct with surgery, for example, my opinion, and we use in my ICU, is to put the patients in moderate hypothermia when using ECMO. Of course, only in patients who are intubated and sedated. The study include only this patient and not patients who are spontaneously breathing, which is, I think, half of the patients now.
Of course, so some people could argue that how can we understand or identify the patients who would most benefit? Is it because hypothermia protect, for example, the brain after cardiac arrest, or is because hypothermia has a protective effect on inflammation, on the heart, on maybe organ dysfunction? Do you think that your results can help to select the patients, or if you want to apply it, just apply it to cardiogenic shock on VA-ECMO?
Yeah, I don't know. If we look at the forest plot, maybe we can see that patients with a higher lactate level might be more beneficial when we use hypothermia. But there is no data in the study that can prove that in this patient I have to use hypothermia when compared to another patient. So because we don't have any adverse effects, because it's without any cost, I think that we might use hypothermia in this kind of patient. It's patient, very, very severe patient.
Bruno, we discussed recently in another chat about the new guidelines for temperature control, of course, only for cardiac arrest. So maybe it's a part of the patients. And these new guidelines, basically, we are recommending in general for cardiac arrest of cardiac causes using normothermia. So just to have your personal thoughts, how we can reconcile these two positions. On one side, the feeling that in cardiac arrest of cardiac origin, normothermia would be the first choice. And in a disease like cardiogenic shock, which is mainly heart disease, when it's very severe, then we go for hypothermia, remembering that in the TTM2 study, we had more adverse event, hemodynamic ones, when hypothermia was used.
Yes, but we have ECMO. We use ECMO, so it's very easy for VR. So, for example, in the TTM, there are more arrhythmia, but arrhythmia is not a big problem in patients with ECMO. And the population are very different. If we consider the hypo-ECMO patients, 100% of the patients had ECMO, and the TTM is very, very small number. Approximately 50% had cardiac arrest when compared to 100%. So it's not the same patient. It's another disease. And you know that patient with ECMO, ischemic reperfusion is very, very difficult to treat. It's a very big event to consider. And maybe it's the reason why hypothermia seems to have an effect.
Very good. Now, my point would be that this is a study that will certainly influence practices. Do you think that your study is the last one in this field, or do you think that because of this discussion on statistics and number of patients and power, people will program to do a new study? I mean, is it easy to do a study on VA-ECMO? Because my feeling is that It's not easy to do studies in ECMO. Do you think that someone else will replicate your data, or this will remain the ones available for years?
No, for a lot of reasons. First, because there is now at least 6 to 7 big studies on VA-ECMO. So patient with VA-ECMO is a rare disease. So we have, I think, 6 to 7 years to perform these studies. Second, I'm not sure about adding patients we add value to the study. I think that we might use the results reasonably in patients in which we do not consider that hypothermia may increase the adverse effects. And I think that for me, it's the last study on these topics, hypothermia and VA.
I have a last practical question for you. Imagine that tomorrow people are convinced, and then when they have a VA-ECMO with cardiogenic shock, they initiate hypothermia. Do you think that some patients might receive longer exposure to hypothermia? Because in the study it was 24 hours, and then it was a very slow rewarming phase, almost 2 days of intervention. Do you think that in some patients, maybe with those with a severe injury, you may even think to prolong therapy, as we have done already in cardiac arrest, showing that it's safe as 24 hours, and people do for example, neonatal asphyxia?
I don't know. Really, I don't know. I don't know. There is a paper which was published this month in Journal of Cardiac Failure. It's a retrospective study, and they found that patients with hypothermia used during via ECMO, they found that the time to exposure to hypothermia was more important than to the temperature. So I don't know. Maybe a patient with very, very high dose of norepinephrine during 1 day, 2 days, maybe benefit from a longer period of hypothermia, but I don't know, Fabio. I think it's safe. Maybe it's safe, but the data that we obtained in the hypo-ECMO study are not sufficient to say, yes, we have to use that.
Thanks, Bruno, because I think this your study will open a lot of discussion in the next meeting. I'm sure that many people will talk about VA-ECMO and hypothermia during ECM and the next ICU meeting. Thanks for the contribution you made for the science with this great paper, and I hope to see you soon in the next ECM chat.
Thanks. It was my pleasure. Bye-bye.
Bye-bye. Bye-bye.
Thanks.